Hi, everyone. Welcome to another episode of Orthopod. My name is Mo Bandari. I'm the editor-in-chief of Ortho Evidence. And from time to time, we get real insights from surgeons on the front lines and also surgeons who have experience with issues that I think many of us often don't get that experience. And I'm here today with Dr. Amal Khoury, who I think shares a very unique history and also has unique perspectives. Welcome, Amal.
Hello, Mike.
So I wonder if you might, just for our listeners and our viewers, just give a little bit about your background and the context for our discussion.
Well, I'm an orthopedic trauma surgeon. I trained in Jerusalem, did my fellowship in Toronto, and I've been heading the trauma unit at Hadassah Hospital for quite a few years. And now I'm heading the division of orthopedic surgery at Tel Aviv Medical Center, which is in the heart of Tel Aviv. Yeah.
So you obviously have a considerable amount of experience with it in general, right? When it comes to trauma management. What for you, when you look back at just conflict in general and conflict zones, what have been the priorities for you, and what can you share with us around, the issues of the challenges and the needs, in conflict zones?
It depends from war to war, from type of injury to another type of injury. We gained a lot of experience during the 2000s with blast injuries, during the bus bombings, mm-hmm. which is bombings in a confined or a semi-confined spaces. Well, that's a completely different stories. What we've been dealing with lately is basically more missiles and penetrating injuries, along with blast injuries, of course. I mean, it depends where you are, in which space you are. Luckily, we didn't, during the last events, this little war we had in Gaza, we were completely prepared, but we didn't really use our resources because we didn't have mass casualties. The funny thing, well, it's funny, but during that time, we had a crash of a stadium. I don't know if you've seen this in Toronto on the news, but a kind of a little stadium just crashed. We had a lot of. It was a mass casualty, but not related to the war. If I have a message, I mean, it depends from one system to another system. In Israel, for example, in order to evacuate from most of the cities, in any place in most of the cities, the top time of evacuation would be less than half an hour. Unless one road in Israel, which leads to Eilat, which is down south, there we need helicopters. Otherwise, we can evacuate from any place in Israel with an ambulance to a close hospital within a few minutes to half an hour. Well, that's completely different from, for example, in Ontario, it's a completely different story where you can, travel for hours in order to get from one place to another place. So, yes, your priorities, your preparedness is based on the facility you live on, the country you live in, and how close you are or how far you are from any medical facility. What definitely makes a difference is the preparedness. And no matter what you do, without drills, you can't be prepared. We learned a lot of lessons, and I think the smartest things is to learn from lessons from other people before you have to. People has gone through these events. They learned the lessons, so let's put them all together. And we actually wrote we have a lot of literature coming out of Israel regarding mass casualty events. There's a lot of evidence, and there's a lot of literature coming out from the Iraq War, which is a completely different stories. where the closest place to evacuate, a friendly place, would be probably a field kind of a hospital, and the next place would be like a place in Germany or whatsoever. So it's a completely different story. Where we are talking now about cities and mass casualties in cities. I think every hospital needs to be completely prepared. I think many of the hospitals in many countries had a lot of interest during the 2000s when we started to see all the terror attacks in the mega cities. And I think many of the hospitals, including Canada, have their own these big books of preparedness, but without drills, nobody under. I mean, you have new generations that haven't gone through this, didn't live this. So the idea is to have drills and drills and drills and drills. I myself, we had a lot of experience during, as I said, the beginning of the 2000s. Or beginning of the millennium, it's called, put it this way. And now, 15 years later, when we are getting, prepared to this last war we had, me with all my experience, I found out that I need again to practice and to create the new algorithms, new formats based on the lessons learned at that time.
So can you speak a little bit to what are some of these new lessons? So when you said you have to relearn, what was it that you were thinking that is different now than it was before?
It's mainly technical. Let me give you an example. Yes. Okay, you get now 30 injured people from a combat zone into your ER, okay? And you declared a mass casualty event in your hospital, and you have all the people coming out, okay? Now it goes down to the basics, okay? So you have 30 people, you don't know who they are, who they're coming from, okay? And and they have the sticker on with a number. Okay. Now this number is related later on when you know who these people are. When you identify them, it's related to the specific identity. But on the way, you have also imagings and ultrasounds and many other studies you've done, and you have to relate. So it goes back to we have new digital systems, we have new ITs. So yes, I mean, you might be the best surgeon, the best hospital with the most expensive equipment, but if you are not prepared from the level of identifying your patient, or it's the patient's imaging, I mean, you've lost your battle, because next day you'll be trying to relate X-rays to patients, and it's quite impossible.
So I can imagine that. And so in the most recent situation, have you found yourself making those adaptations? So for example, how common is error without thinking about those technical issues? Because you can imagine misdiagnosing or underdiagnosing somebody, right, based on the incorrect X-ray could be life-threatening.
Luckily enough, as I told you before we started the interview, we didn't have a lot of patients. Yeah. We basically didn't have real mass casualties events, but we had a limited, what we call limited mass casualty. And the next day, that it was a big bless that it was a limited mass casualty, because next day we found out all those technical issues, and then you have to collect all the team and learn your lessons again. Okay, so what went wrong, and how can we improve next time? And that's what we've done. And we already learned the lesson, we corrected it, and now if we have, God forbid, any reason to use it, we are prepared for that until we face another obstacle.
Understood. So tell me, maybe just in the last few minutes here, the focus today has really been on preparedness. What does a drill look like? You said that it's important to run preparedness drills. So what would a typical drill be, and how would one organize such thing?
I'll give you an example. Again, it depends from one system to another system.
Sure.
So a drill would be that you declare as a hospital that we have a mass casualty event, and you basically play the role of a real event where everybody gets into place. Okay, I'm the chief of orthopedics, so I know exactly where I have to be. The chief of surgery knows exactly where he has to be. Usually in the triage area, we put the most experienced people at the triage area at the very beginning of the. Okay, and then you know who runs the event. You need one person to run the event, where he starts with the triage. And then once in a while, once in a few minutes, we call it the accordion system, or whatever you call it, where you have to reconvene, and then you split again, and then come back again, and you learn your lesson again. You have people dressed. We have actors sometimes playing as victims. We have it's a real. It looks like a real thing. People have their own, like vests with colors to be identified as their role in that event. Again, you run all the systems from the IT registry, imaging, trauma bay. You evacuate the ER. You play it as if it was a real thing.
Wow. And can you give me one other example? So how often are you running these drills?
It used to be more often. Now I'm quite new in Tel Aviv. I'm there for a year and a half. And that was the first drill, but it wasn't drill. It was a real thing.
Wow.
So yes, I mean, you would like to do it more than you do it, actually. Yeah. But I think every hospital should be prepared at least once a year or once in 2 years.
Yeah, run these. Well, I can't thank you enough. You've given us some insight, and I think the message today really is about what we do in preparation for conflict or for a mass casualty. We hope we'd ever have to deal with them. That seems like you've dealt with more than your share. So. Yeah, but let's hope that there's many fewer for you in the near future. But Dr. Khoury, thank you so much for taking time with us at Ortho Evidence.
Thank you.
Appreciate all your time.